Okay, good morning, everyone. I'm Melissa Wilkinson from the Hunter New England Central Coast Education Team. I'd like to acknowledge the local custodians on the lands which we're meeting this morning and honour elders past, present and emerging. This session is recorded and will be available. The link will be shared after the event via email. Today's presenter is the lovely Sarah Houlihan. Thank you for being with us, Sarah, from the PHN, and she's our PCI. The topic is care planning, creating quality care plans to improve patient outcomes. I encourage you to use the chat box, type those in there. You are muted, but if you can use the chat box, we'll be happy to answer any questions that you have in there. The mics are muted. The link to the evaluation I've popped into the chat box, and I'll redo that towards the end of the session as well. Just to let you know, it's www.slido.com, and the password this time is VT April. So yeah, we really appreciate if you could complete that. That's how we get our data to plan further events. So we really appreciate it. And it takes a couple of minutes. Okay, I'm going to now hand over to Georgia to open us up. Thanks, Georgia.
Thanks, Melissa, and welcome everyone. Hopefully we'll have more people join in as the morning goes on, but others might watch the recording later on. But the topic of care planning is a very important one in general practice for a variety of reasons. You know, for the junior doctors and the medical students, it's important to know about care planning because it's a way we can really, you know, manage multidisciplinary care and enable patients to utilise MBS item numbers for allied health, which is particularly useful if patients don't have, you know, private health insurance and can't really afford to see allied health like physios and dietitians. So, so today, Sarah and Heidi, they're the gurus. They will enlighten us of some little tips of the trade. And I'll be following the chat box because we want to make this as interactive as we can. So please feel free to ask questions along the way. And then we'll have some time to chat at the end as well. So Sarah, I think Sarah's starting first. Take it away.
Thanks, Georgia. So I wish to acknowledge the Darkinjung people as the traditional custodians of the land here on the coast, where I live and work, as along with many of you. I extend my respect to elders and any First Nations people who may join us online today. My name's Sarah, I'm Primary Care Improvement Officer in the PHN Urban team. I'm based in the northern end of the Central Coast. I've been a nurse for around 20 years, and most of that time has been spent working in general practice. I have a passion for preventative and proactive care, so care planning really is my jam. I will have to log off towards the end of the presentation, but Georgia and Heidi will be around to continue on the discussion after I have to go. So our main, of course, care planning is such a huge topic. I've tried to split it into basically the need to know kind of stuff in terms of what we're referring to, patients who are eligible, the Medicare requirements that we need to meet, the difference between a basic and comprehensive plan and the benefits of those, things that we need to consider for our First Nations people, and then some other services that are available to be able to support you. I will pause between topics to be able to answer any questions as they come in. So care planning, of course, is known by so many different names, and they all essentially mean the same thing. You'll see throughout the slides that the terms are generally interchangeable, depending on whether you're looking at Department of Health or Medicare or talking to colleagues who have known it by different names. Essentially, as long as your patient understands what you're talking about and can give informed consent, it doesn't really matter. For the purposes of today, we'll use the broad term of care planning, but you will see different terms along the way as well. So the patient's regular GP is considered by Medicare to be the GP or a GP within the practice who has provided the majority of care for the past 12 months, or in the case of a patient who has joined your practice and states that you will be their regular GP, the GP who is likely to provide the majority of care for the coming 12 months. There's no set list of conditions that are eligible for chronic disease management, as GPs are expected to use their clinical judgment in determining which patients require a planned approach to their care. The Department of Health and MBS use some examples like asthma, cancer, cardiovascular illness, diabetes, musculoskeletal conditions, and stroke, but they do also acknowledge that chronic conditions can occur across a wide spectrum of severity and in a broad range of circumstances. So it's a busy slide, but what we've got here is essentially snips from the MBS regarding the requirements for Medicare for billing. So in the slide, you can see that the minimum requirements for care planning include obviously discussing the plan with the patient, setting goals, and outlining who's going to do what, how, and when. When we're talking about a team care arrangement, essentially we are including the same information as in the GP management plan, but also then collaborating with at least 2 other providers to be part of that care. So although the patient may have multiple providers who are part of that team care, and you're welcome to collaborate with all of them if you like, the minimum for Medicare is that you will have a chat with at least 2 of them. There's a link coming up in the slides which will take you to much more information about this, but collaboration before billing a team care arrangement can be a fairly common oversight, and I have heard of local GPs being pulled up on this, especially if they're consistently billing a 721, 723 on the same day before receiving correspondence back from other providers. So that's something to keep in mind. So when we're talking about collaboration, the provider that you are referring to needs to be aware of the individual needs of this patient and provide feedback to you of exactly what they will be providing in terms of individual care. Department of Health says it's not enough to have a blanket agreement that, say, your podiatrist who rents a room will accept all team care referrals for foot care. They need to specifically say, will it be nail care or skin care or sensory and circulatory checks, fitting of orthotics, education, that sort of thing. It does need to be quite specific to the individual needs of the patient. And then once you've received feedback from the collaborating providers, then you are able to bill the 723.
Georgia, can I ask a question there?
Yes.
Sorry, it's Chris saying here. I reckon this is the hardest part from a process point of view as a practice, and we've had lots of trouble over the years trying to sort this out, because I think it's fine in theory, but I think the reality is that this doesn't happen. And what we found, so we went for a period where we were billing the 721, 723 on the same day. Then we tried to do where we bill the 721, but we don't bill the 723 until we hear back. But then you don't hear back. And then all of a sudden you get to 6 months and the 723 didn't get billed because no one heard back. So I don't know, I'd be interested if there's anyone else or if you know of any good processes to work for this, because I think this is a real problem with the process. And the way that we collaborate as well is that we send a fax to the provider with a copy of the care plan. They sign it and send it back, but that doesn't really sound like it's meeting what you're talking about there with the specifics of what they'll be providing. So I'd be interested in that too. I just think it's a problem because we don't have time to call all these people. The podiatrist doesn't want to talk to me about every diabetic patient just to say, yeah, I'll do a foot check. So it's, just be interested to hear thoughts on that.
We do the same, Chris. We send a fax as well and get one back, but now I'm enlarged into it might not be specific enough. And I suppose the other part of that is if the patient has been seeing the podiatrist yearly and we're just renewing it, and we've already got information in the past, can you presume that we can bill that 723 straight away because they're already involved in the care? Just say if it was a repeat care plan, does that count?
For a review, it does, Georgia, but they do state that if you're doing a new plan, so that 721, 723, that you would have a chat with them about what will happen in the future. And Chris, you're absolutely right. This is a really tricky part, and you're not alone with this. I think this is the biggest thing that most practices will struggle with, and what you described probably is the most common way that GPs are. They'll either send an email or a fax, or because often even if they are allied health that work on site, they might only be there one day a week or once a fortnight, so it's not always that easy to sit down with them and, or to give them a call and say, hey, you're willing to take this patient. So yeah, it is a tricky one.
And with the 723, so is the idea, because I guess the question is, if you see the patient, you do the 721, all this paperwork happens, hopefully you hear something within the month, but sometimes you don't, particularly from specialists. They often don't sign the TCAs. So do you then backdate the 723 to the same day as the 721, or do you bill it on the day that you've received that information? And then all of a sudden you're out of sync. So when you said, I'll bring you back at 3 months, well, actually it's not 3 months from the TCA anymore. I mean, I usually bring them back at 6 months, so you've got a bit of a buffer there. But yeah, so are you going back and billing 723 on that first day, or are you doing it when?
I'm pretty sure it's date
I
of
can
service.
answer that one if you like, Sarah.
Oh, cool.
Thanks.
Yeah, so what practices or what I'm encouraging practices to do is when they have their GPMP and their TCA done together, you would bill out the GPMP on that particular day. You would put your TCA on hold for that day. Then once you get that correspondence back, you would go back into your held accounts and you would bill it back out. So when you bill it out, it would bill out back to the date that it was completed. So that has been confirmed with Medicare. That's how Medicare want it done. They said that you shouldn't be billing it out on the day it's been approved because you don't actually have the patient there. So it needs to be backdated to the date that the patient was with you. And so that's how it should happen. Now, we all know that that's not realistic a lot of the time, because if patients need urgent care, if you haven't received that back, that then means that you can't bill the TCA, which then means the provider, like the allied health provider, can't bill to Medicare. So that means the patient then is out of pocket. So this is where it gets really complex. So I personally, when I was in practice, I used to make sure that the allied health providers that we engage with regularly, I would send them out a bit of a letter as to what your requirements are, because this is the breakdown between general practice and allied health providers. Is sometimes allied health providers don't understand what the GP requirements are. So I would, and I do have a fact sheet, that fact sheet I shared with you yesterday, Sarah, about like what the role of the allied health provider is. So I'm happy to share that. You could always send that off with a covering letter saying, look, as part of our team care arrangements, this is the requirements for the best possible, like for the best care for our patients. Please consider this when we're referring to you. And then maybe even saying that, like, if providers aren't going to comply, we're going to have to look at alternatives, so that they do understand their obligations, because at the end of the day, you don't want your patients to be compromised of care.
I think Dimity had a question as well, I think.
Well, it's really a comment.
Yes.
I've got exactly the same issues, and I also do both and fax them out. And so what? So the thing is that you need two people to agree to a care plan, and it could be a specialist in allied health, or it could be two allied health providers. So our practice has a physio next door, an optometrist on the other side, and the podiatrist actually works in the practice. And those three people, those three allied health providers, understand very well our needs because we're able to actually physically communicate with them. So what we tend to, and sort of, I don't know, but must be more than 80% of my older patients go to the podiatrist. So what we tend to do is include the podiatrist and the physio, or, you know, if they're going to the physio, and the optometrist on the care plan. You can tell me if this is wrong. And then whoever it is that they particularly want to see, a chiropractor in Outer Whoop Whoop or something, but we're not expecting that chiropractor to understand. We don't know this person, although they're the one that's going to benefit from you know, getting the patient getting the money back from Medicare. We don't rely on them. We rely on the other providers that are tried and true, that are also on the care plan, so that we can get to back quite quickly and reliably from them. So that, I don't know if that's a hint or a tip that you can use, but that's certainly what we do in our practice.
And I'd agree with that, Dimity. You know, I worked for a long time in a super clinic where we had a lot of stuff on site, and we did the same thing. You know, so because we knew that a lot of our on-site providers were already involved in the care of the patient, so even if they weren't the ones that we were actually referring out to because the patient wanted to go and see somebody else, if they were part of the plan, yeah, we would do that as well, just for ease of getting things signed off, basically, so that the patient, because it's when you've got the specialist, if you're waiting, especially specialists, if you're waiting to get back a TCA, you know, confirmation from them, they, you know, one, don't have time, but two, don't really realise that that's actually holding up the patient from accessing their allied health services. So yeah, use what you have, I guess, is the key there.
One thing that I will add to that, though, if another provider is seeing your patients, they do have a requirement to give you some information on the treatment plan for your patients. So they should be advising you of what they're actually doing.
So Heidi, the podiatrist does corns and callosities. Callosities is not my word; it comes from the podiatrist. And that's what they do. That's what they write in just about everybody's. I mean, some people have specific requirements, and you know, they've often been doing that for 5 years. So would you expect something? Would Medicare, if they were auditing us, would they expect something handwritten or something from the podiatrist when it's the same year in, year out?
Look, that's a tough one. I have been involved with audits, and it depends on who is actually auditing as to what they're looking for. From what you're saying, I think that would be more of a concern to the allied health provider as to if they get audited. They may see that as not enough information, but look, I think as long as you've got something back, you should be okay. I can't say that yes, you'll be fine, because as I said, it depends on an audit as to what they're actually looking for.
And it does say in the, which is coming up in a couple of slides, that that the department actually prefers that it's done verbally. So in that
Yes.
case, you're not going to have something in writing. It's more just documenting, you know, nurse had discussion with this person, you know, this allied health provider. This is what they have agreed to for this patient. And sometimes that might be they have agreed they will continue to provide the current care, which is XYZ. So yeah, you've got that documentation to back you up. It doesn't have to be formal at all. So often I see stuff, especially in nursing groups, about people saying, I sent it off to the allied health provider for consent, but it's actually not consent, it's collaboration or feedback. So yeah, I guess that's the thing to keep in mind with that sort of question. Do we need it in writing? Not necessarily. It just needs to be documented.
Can I say something else, Chris? I don't know. Or Georgia, you're chairing, aren't you? Can
Yeah.
I make another comment?
Right.
Yes, of course.
I mean, I think we need to not lose track of the point. So, so I had this memorable occasion where my elderly patient on a walker, you know, using a walker, was walking down the corridor, which is longish, to my room. And she was complaining to me that since her hip operation, she felt that one leg was shorter than the other and it was harder to walk. And she walked past the podiatrist room and the podiatrist was in there and the door was open. So I said to the podiatrist, as we were, you know, we were walking very slowly, I said, do you look at leg length? And she said, well, hang on, I'll come out and have a look. So my patient was continuing to shuffle towards my room. The podiatrist came out and went, no, that's not a leg length problem. That's a muscle tightness problem from around the wound. You need the physio. So the physio was up the corridor and I just asked the physio to come and have a look. And she said, oh yeah, that's something I could probably deal with. That's quite common after a hip operation. And that is what we need allied health for. I mean, this paperwork is kind of, would never be able to pick up that dynamic, helpful, collaborative interaction between three people. And I learned such a lot from that as well. It was really good. And the patient was happy. So, anyway, I suppose that undermines the point of the talk. We do need to get the paperwork right. Sorry. But...
No, look, you're right, Timothy, and that there, I mean, that's ideal collaboration, isn't it? You know, so that, and that's what they're talking about. That's not in writing. That wasn't a fax. That was literally saying to your allied health provider on site, is this something that you can help with? No, it's not me, it's this one. Whereas had we just sent off a fax to the podiatrist, you can see there where it does hold it up a little bit. So knowing what each allied health can do, of course, is really handy there too. So
totally. I think that really the whole idea of fragmented care, like it definitely makes sense to have a multidisciplinary team in a practice looking after patients. And it's just unfortunate with the current model with private practice, it just doesn't work in all settings. But great example, Demi. I wish all practices had that access to allied health. Would be great.
Yeah, absolutely. I might keep going if that's all right. Where are we on this one? So just a reminder around who can assist you in preparing the plans. So that is health professionals like your practice nurses, so an EN or RN, an Aboriginal Torres Strait Islander health practitioner or an Aboriginal health worker. But of course, the GP must review and confirm all assessments arrangements and see the patient either in person or via video telehealth. Your non-clinical staff, like your receptionist, practice manager, AINs or MPAs, can assist with the logistics of the process. So, you know, recalling patients, maintaining registers, making appointments, that sort of thing. But obviously, if they're non-clinical, they should not be identifying health and care needs or assessing the patient. The other question we often notice a bit of confusion around is how often the plans should be reviewed and renewed. So the GP management plans and team care arrangements are recommended to be reviewed around every 6 months. You can review them as often as 3 months where clinically necessary. New plans are recommended to be about every 2 years, but they can be completed after 12 months where clinically necessary. Thanks, Heidi. I've cut and pasted a little bit of questions out of the document that says Department of Health question and answers, because these questions here on the slide are the ones that we probably most commonly get at PHN, and all of those answers are there. So rather than trying to interpret and answer and whatnot, they're all there for you. The link will take you to the answers for all of those. And then we've also got the link down in the bottom left for the explanatory notes for care planning items on the MBS checker there.
Sarah, because it's always been controversial whether you can include like obesity, because they say that's not a chronic diagnosis. So that's, and then I think even hypertension. So I'm not sure. I'll have to have a look at that list and clear that up a bit further. But that's always been tricky. I still put things like that in my care plan, but they still need a set chronic disease as well.
Yeah, and they do specify, there was a list of them, so there were things exactly like that: obesity, hypertension, high cholesterol, pre-diabetes sort of stuff, drug and alcohol. So there were a few things there that were a bit kind of, the department says that in and of themselves, one of those conditions probably isn't considered to be a chronic disease. However, we know, looking holistically at the patient, that they normally are either got a comorbidity to other things that they've got going on, or in and of themselves, they are a really tricky condition to manage, in which case they may benefit from that planned and coordinated care. So they do allow exceptions for it. I guess it's just looking at, would it pass the pub test? We can't put every patient with a impaired glucose on a care plan, but if you had someone who had quite a few of those risk factors, then yeah, that could be beneficial for them.
And we just have one other question, sorry, from Shabashi, is can a non-regular GP do a review of a GP management plan team care arrangement?
Yeah, as long as they're caring for the patient or in the practice. There's different item numbers for, I know when you say non-regular GP, as in just a non-VR, is that?
I think it might be just not their regular GP, but I presume, you might want to elaborate, Shabashi, but I presume it's maybe their regular GP's not there, or if you're a registrar, you might not have done the initial plan, but you'll review them because their previous doctor's not there anymore.
Yeah, and that's coming under the regular patient of the practice. So because absolutely registrars are often in that situation, and like you say, when you're covering leave and that sort of thing, so yes, you can, provided that the patient has been under the regular care or will be under the regular care of one of your normal GPs. Yeah. So, and for that, another VR GP, and non-VRs can as well. They just use different item numbers.
Sarah, can I just add to that? If you are reviewing a care plan that you didn't create, I would have a conversation in your practice to make sure that everyone is in agreement. You don't want to upset somebody else by reviewing their care plan, because at the end of the day, it is a business as well. So everyone is making their own income. So you have to factor in when you're going to be doing care plans when they belong to other GPs. So just have those conversations in the practice. It's something that usually your practice manager can address, but I would certainly have the conversation first before reviewing somebody else's care plan.
Yeah, and that's a really good point, Heidi, because there's a difference between, like, a registrar who's taken over the care of the patient, as opposed to the GP's on leave this week, but they'll be back next week. Well, there's no urgency on reviewing a care plan, so it could wait until their regular GP's back. So, yeah, using a bit of judgment there, and that's where you really need to have the whole admin team as well on board with that one, and understanding why it's beneficial for the patient to get that continuity of care. So with developing the plans, that we talk a bit about patient actions, and that's something that is certainly addressed in the MBS item numbers and also on the Department of Health question and answers sheet. So the most common patient action I will normally discuss with patients is around identifying concerns with their health and seeking help early. Because we know, potentially preventable hospitalizations is a huge thing for these chronic diseases. And I find that really empowers the patient that they are the expert of their own body, and reinforces that there is an expectation on them for some self-management as well. Part of care planning that I will always talk to patients about is proactively planning their care for all the things that we know that they're going to need, scripts and referrals and reviews and nurse follow-ups. We there's really no reason why our chronic disease patients who are on plans should be needing things like urgent scripts for their regular medications or referrals at short notice. I mean, that's the whole point of having a coordinated approach. And of course, that makes life much easier for the patient. They're not stressing about it, but also for you and your practice, not trying to fit them in at the last minute. So questions we often get are around, can we just do a plan for one condition, for example, say a diabetic care plan? The answer to that is not really, because it's about a plan for the patient, not a condition. So regardless of what your template might be called, diabetic care plan, because that's already got a lot of the pre-filled stuff in it, everyone is going to look different because depending on their own comorbidities and their health status and what else they're going to need throughout the year. And then there's a reminder there around the SMART goals of making sure that the goals that you're setting for the patients are specific, measurable, agreed, realistic and time-bound. And I know what I just said is different to the image, but obviously it depends on where you see it. And we want to reduce things, and I've seen it in plans, reduce HbA1c by 1%, which means absolutely nothing to patients. Whereas for a patient to have a SMART goal, it might be, take your blood sugars twice a day before you eat, write it in the book. We'll review it in 4 months. If you've got 3 readings or more above the agreed number, give us a call to the nurse for a follow-up visit, who will collaborate with the GP and provide some advice. So really simple kind of stuff for the patient to be able to follow, that's actually going to mean something to them. So I thought it might help to do a bit of a scenario. So Anne Smith has recently joined your practice. Her GP has retired. On receiving her file transfer, this is what you find as her care plan, which is a little like a health summary. Whilst technically this plan does tick the boxes for MBS, it really doesn't provide any insight into her actual needs. The goals are vague. Treatment expectations of other providers is non-specific. It doesn't help team members really understand exactly what is provided, either from themselves or what other providers are doing for the patient. And when we look at Anne's active conditions and medication list, she's clearly got some complex health issues. So this version of a care plan is not going to serve this patient well at all. So thankfully, a few weeks later, Anne is now eligible for a new GP management plan and team care arrangement. So you know that the $200 odd that Medicare will pay for these services justifies the development of a comprehensive plan. Your practice understands that development of plans like this take time. They may employ a nurse to assist in the plan so that you can continue seeing patients whilst the time is being spent preparing the plan. Which of course is going to give you, your patients, much more access to you, and also helps with the money flow as well, because you're seeing your regular patients rather than being held up for a long time with one patient, doing essentially paperwork and organising and coordinating. The other advantage, of course, if you do have a team within the practice and you've got your nurse assisting with this, is that they're building relationships as well. So then they're a lot more receptive to having that team within your practice of, your admin, your nurse, yourself, looking after them. And it's reassuring them that we are not doing things to them, we're not doing things for them, but we're doing things with them. We are equal members of the team alongside them. Now, to be fair, this is a really comprehensive plan because this patient, Anne, has some very tricky issues, but this is based on a real patient and a replica of their actual plan. So whilst Medicare only requires the minimum of 2 other providers, in a situation like this where there are already multiple providers involved, it really helps everyone in the team to know who does what, to make sure nothing's getting missed. And I particularly like this one. I mean, this was just a template, but I really do like that it's got that list at the end. You know, it's almost like a cheat sheet of everybody who's involved in the care. Can you see?
Can I ask something or make a comment?
Please.
Yep. That care plan's got a very nice summary of what the home care people are doing. On the towards the bottom of the middle page. And I never know what the home care people are doing. Does anyone else have the home care details like that? Because I need to find out what they're doing often. I'd love to know. And people with a bit of cognitive impairment, which is a lot of my older patients, can't really tell me.
That's a really good point, Timothy. And to be honest, this plan is actually for someone that I know personally. So it probably does have a little bit more detail in it because I'm privy to outside of the medical side of it. But yeah, that's a really good question. Because often we do get, we are referring patients off to My Aged Care. And then other than the actual assessment being done to say, yes, they're eligible for this, we often don't hear back from them. So it's probably a good point around trying to establish relationships, I guess, with whoever their care provider is about what they're actually doing for the patient, so that we know.
I think that would be a great role for a PHN.
Yeah.
Because I think, I mean, and people complain to me, I can't get to that specialist because they're too far away or something. But I mean, actually they can, because there's community transport, and usually they're at least at level 1. But sometimes they've slipped through the cracks, or they don't remember that they've got that. And having all that down there on the care plan would really help. Yeah.
This is where a social worker would be really useful to have in general practice. Like, I find a lot of this stuff, again, if you had a system like the hospital, work a lot better, because as a GP, like I do this, I call, people to find out this information, but a lot of this stuff is done in your own time. It's not paid because you don't have a patient in front of you. So you can see, and GPs are time poor, so you can see why GPs don't do this. They don't spend time picking up the phone and calling the home care group to find out exactly what they're doing with their patient. So again, it's this whole thing of, it's just that it's very hard to get this information in the current setup, the way we practice, unfortunately. But I agree, it'd be really useful to know this stuff. So.
Yeah, there's definitely some good ideas there. I've made a note, and I think that's something that Heidi and I would probably enjoy playing with, about how to, because especially when you're talking about things like home care, or for kids, their teachers' aides, those things that are sort of outside the square, it is so good to know exactly how they're helping, because that's their whole care, not just medical. But yeah, because they can't be a formal provider as such under the Medicare model, how we can try and get some information back from them about what they're actually doing.
And even the exercise class which you've got there on the 3rd page, all that sort of thing, that's handy too. Any of that social prescribing stuff too.
Yeah. I remember when early on when I started practice nursing, and we actually had those life scripts, where we tear off the piece of paper and say, right, this is what we want you to do, and here's somewhere to think. And then they all just kind of disappeared. But they were really handy tools, and I am hearing a lot more around the medical community about that lifestyle prescribing, which would be great to get back to, getting patients out in the community. And they were things they had to take responsibility for themselves, where it wasn't quite so formal. So yeah, there's definitely some food for thought there. Thank you, Dimity. We will follow that one up.
Sorry.
I'll just say quickly, we've got a medical student group at the moment who are doing brief assessments on patients, including a timed up and go test, and then feeding back that information to the GP later in the year, hopefully, in order to modify the care plan. And their outcome will be changes to the care plan based on things like mobility and depression, and patients express needs for social support and stuff like that. Yeah. Sorry, I'll shut up.
No, that sounds fantastic. And that's really good to know that that's happening in the background as well. I'm sure they could probably give us some ideas. On here, I'm not particularly going to talk to anything here. This is more just some ideas of the outside the square. You know, we know about obviously having as part of the patient's care, you know, your specialists in allied health, but so many of the other services that can be, of course, part of the patient's care are often things that we may not think about. And I know you were saying before, I think it was Chris saying about, you know, transport or you know, when I was doing a care plan for a patient the other day, you know, and for them, housing was actually a huge part of their care plan. You know, so having Pacific Links was actually, you know, listed in there as this is something that we need to work with if the housing situation is not secure. So often so much more than medical. Yes, and we know that. I thought it was worthwhile having a specific mention for our First Nations people. And obviously we know that there is unfortunately a big disparity in terms of management or incidence of chronic diseases, but also management of them. So what we can do, obviously identifying ethnicity of all of our patients so that we know who our Indigenous patients are, utilising things like closing the gap, PBS, if we need to, utilising the PBS items for over-the-counter medications. I know there's a lot of those meds are often for acute care, but certainly they do have things like Panadol Osteo and aspirin. So if these are things that are going to be an issue for your patient to be taking, if they can be getting those on a CTG script, either for free or for a couple of dollars, it may just improve their compliance. Where's my notes? And we often get questions about the integrated team care. So I've put the link in there. So on the coast, our ITC provider is through Yeren. And the referral is based online. If you've got a patient with any of the 5 identified chronic diseases, so that's diabetes, cancer, respiratory, cardiovascular or kidney, and you find that you've got those Indigenous patients who need a bit of extra support, so that might be a health worker going with them to appointments, transport, out-of-pocket costs, anything like that, relating to those targeted diseases, that's something that you can consider referring out. To be able to accept your referral, they will need a copy of the care plan with the integrated team care or ITC listed as this is what we would like them to provide for you. On here, I've just put a list of things that I know are really common relating to care plans, chronic disease care plans. Each of them, of course, are quite complex in themselves. So I haven't gone into them. These are all links so that once you've got the slides, if you wanted to read more about any of them, you're welcome to. And certainly if you wanted to learn more about any of these, we can always come back and have a chat another time. But I just thought that is handy to put in there. And then finally, these are just some of the tools that you have available to assist you with your care planning. Now, of course, there are lots of programs out there that can help you. Each of them, yes, with their own pros and cons and costs. These ones are provided to you fully funded or free. So at the top, we've got Top Bar. That is a point of care tool. So you can see in the example, it will give you tips based on the patient file that you have open in front of you on care opportunities and billing opportunities. Down the bottom is your Cat4. So that's more for searching. You can either search for cohorts of patients or individual patients to look for, and there's all sorts of searches you can do on there. And most of our practices on the coast do have this already in practice. So these are tools that are already available to you. And then the other one, which I've put some snips of down the side, is Lumos. And this is more looking at practice level data. It's not identifiable. It's not, it can't be broken down to individual patients like we can with Cat4, but it does give you some really good ideas around, you know, the number of your chronic disease patients who are having, you know, unplanned hospitalizations, or when they're presenting to the emergency department, whether it's an acute or a chronic issue, time before and after an ED presentation to the GP. And there's lots more information than this. I've just picked out what's actually relevant to care planning. So if they're, as I say, these are all available to your practice already. If you wanted to know more, just reach out to your primary care improvement officer and we can help. And that's pretty much it for me.
And my apologies for jumping off slide, but every time I moved, it would jump to the next slide. So my apologies.
Thank you for driving it, Heidi. It's
That's okay.
It's actually worked out quite good time that I didn't have to jump off too early. So yeah, thank you, Georgia, for letting us come and chat with you about it.
Well, thank you, Sarah. Like, again, you know, we find it hard as GPs because there's so much red tape, but we just want to be able to, you know, manage their chronic diseases. So I still find it mind-boggling, all the ins and outs and the requirements. So I thought I was doing the right thing, just sending a letter to the allied health podiatrist, I'd sign it, and I thought I'd fill the requirements. And now that I know we have to do a bit more than that, it's to rethink what we do.
Look, it's always hard, isn't it, balancing that requirement versus clinical care as well.
Yes.
You know, like we were talking about with that diabetes cycle of care. Of course, we're still going to keep doing the cycles of care because they're clinical best practice. Yes. But in terms of billing, now we need to adjust how we do that. And yeah, Medicare doesn't always, I guess, work with us on that one. So we just work with what we've got. But yeah.
And we don't have time to keep tabs on everything as well. Like if I tend to bill my 721, 723s at the same time because I won't remember later on. I'm too busy caring for patients, but luckily the allied health I use, they're very good at returning things the next day, you know, that day or the next day. So I feel like, you know, I would be safe if there was an audit, but if I didn't bill that 723, it would never happen and the patient would get to the physio and they wouldn't get their rebate. So it's that fine line.
Yeah, for sure. I'm really sorry.
Yeah.
I'm going to have to log off because I've got to get some kids off to school. But thank you so much for having me on the meeting this morning. And I might see you again soon.
Thanks so much, Sarah.
Thanks,
Okay.
Sarah.
See you. Bye.
Dimity, sorry, Georgia, did you want me to share your care plan?
Yeah, I just thought I'll give an example, which now probably isn't very good now that I've seen the gold standard. But so, and it might just be more to generate discussion. So I'm happy for people to, you know, turn their cameras on and microphones off, and we can even talk about how we could improve on it. But this first slide is more just our basic sort of template that I've been using. The first one I haven't actually filled out, but it's just. And I must say, I probably have used my care plans more as a problem list as well. If they go to emergency, they've got their little health summary. I have patients that travel a lot or used to travel a lot in their caravan around Australia. So it'd be quite handy for them to have that information. So, you know, initially they've just got, you know, their past medical history and their medication. If we scroll down a little bit further, Heidi, and it just and this auto populates. It's really quick and easy. So we keep on and with the social activities, you can see where I've got recreational activities. That's where, you know, some of their social factors are added in there. So I haven't tended to add that to the actual body of the care plan, but I think I will now after seeing Sarah's example. And yeah, and we. Similar to what Sarah's had, with the patient to have a clear understanding of how the condition is managed. We have a section on lifestyle management as well, where I can add in some specifics. So if they are seeing an exercise physiologist in that section, I can add that under the arrangements. And then we have a patient-centred question, which is similar to what Sarah mentioned, like what's the biggest issue affecting that patient at the moment. So I add that in there. Then we automatically have blood pressure in there, and those blank lines are where we will put in their medical conditions. And we do write down, you know, clearly who's involved, what the goals are. I've got an example further down of what I've done with this patient. I've got the preventative health measures as well, and they remind me. So when I do the review every 3 to 6 months, I can look through when was their last mammogram, when was their last colonoscopy. So it helps trigger my memory as well. And this is an example of what I've put in her case. I don't have all the other stuff with it that I've already shown you, but just what I would put in that body. So I've got what the patient's on, how often with the diabetes I've got there, the eye checks, the foot checks, the recent HbA1cs, and when I do the reviews I just update that every 3 to 6 months. I think this might have been an example of a review actually, because I've added a few things in bold there, so I might have taken this from one of this patient's last reviews. Again, it's not perfect, but it helps remind me, and it's a nice little problem list of what's going on. If they did go to hospital, in Queensland, and they'd be able to see exactly what's going on. So that's just an example, and I'm happy for any feedback on that. And a reminder with their Prolia as well, when that's due. I'll write in dates there, but it just helps keep me up to date. I know we have reminders on their software, but yeah, and then I just add to it in the next year. If there's a changing condition, I'll add that to it as well. So that's just one of my examples, but now I'm going to add in some more.
That looks great. I think it's just important to understand that there is no right or wrong template. You just use whatever you're comfortable with, and what gets the information out there. So you can develop your own template. You can use the ones that are built into the software. It doesn't really matter as long as the information that you're putting in there is relevant and up to date.
Has anyone got any comments? What do they like to add to their care plans?
I know when we were in practice, sorry, Chris, I jumped in over the top of you there. We always put in physical activity, nutrition, things like that, because especially for elderly patients, asking about their nutrition was really important, because sometimes they didn't really eat properly. And if they weren't at that age where they were having a health assessment, that often got missed. So I know our nurses done a lot around nutrition. And I did like in Sarah's how she had about their parking permit when that was due.
Oh,
that's a good idea. Yeah.
Yeah, because so many times we'd have patients would come in for their appointment, then go, and then they'd ring up and say, "Oh, I didn't realise I got a letter in the mail to say my parking is now due." So if you had track of that, it just stops those extended phone calls.
Totally. It's I was just going to say that was great, Georgia. I really like your table, and it's very similar to mine. Mine's just in a different format because we have best practice, so I use the EPC section of best practice. And what I do, because it doesn't have that nice table format that you've got there and the ability to write in comments, so I do a problem list in the patient's files. I just put the title problem list, and then I have each condition with the information next to it, just like you would in hospital on a ward round or whatever. And then what happens is that's in the patient's notes. So I copy and paste that in every 6 months into the next visit, but I also copy and paste that into so you can copy it in the best practice. There's the other at the top of the pop-out screen that comes as an other section or an update section. So you can copy and paste in there, so that when you print it off, the problem list actually falls on the first page of the printout. And then you've got that other section, which is a bit color by numbers, where you just plug in preset. You can free type, but it's a bit, it's not as useful as being able to have, like, you've got, bowel polyps and, colonoscopy 2011 normal needs repeat in 2016, whatever it might be, or had a hypoplastic polyp, whatever. And you can free type that stuff in. And I have a process where at every GP management, I have a very deliberate process of going through the past meal history, making sure that's up to date, the medication list, and looking for drug interactions, and getting rid of eye drops that aren't there anymore, and you know, all that, it's that housekeeping stuff. Like housekeeping is a big part of the care plan
Yes.
for me. Yeah.
Yeah.
And I'm sure we
I find I didn't like the template on best practice, because I like to be able to. So what I was doing during COVID, with the patient's permission, and I know you've got to be careful of security, but I'd email the care plan to the patient, to the allied health provider, email the EPC to them, email them the letter for them to sign, and they'd send it back. Whereas with, unless you know away, Chris, but with the EPC, you can't actually, unless you print it out and scan it, you can't actually email it. And it was quite handy for the patient to have a copy of it in their email. So, and then each time I do a review, I literally do a cut and paste of that table, bring it to the new plan, and then just update it. So it's just so quick and easy. Whereas I just found with the template, but some of our doctors use the template, but I really didn't like it.
Yeah, no, it's true. I just like it because it sets up the reminders automatically. So it's all in the system, and you can look and go, that's when the last TCA. And then if you tick, there's a box you tick, it actually puts the reminder in, I'm pretty sure. Anyway, it seems to work. And I was just going to say,
everyone.
I think Kelly's got a question here. So just to clarify that, Kelly, so the EPC versus TCA. So the team care arrangement is, I mean, I find it lots of duplication. The team care arrangement can look exactly like the GP management plan, really. It's just got the listed providers, but the EPC is the actual form. Is it stand for enhanced primary care or something like that? It's the actual form where you tick, write in, I want 3 visits to the podiatrist, and then you do a separate one for the the diabetes educator, you give 2 visits to diabetes educator. So there's a separate form that has to be attached to the referral to that provider.
I think they've actually changed the name on it. I don't think it's actually called an EPC anymore, but we all know it as an EPC.
Yeah, that's right. Yeah.
But if you go in, if the ones that are using the pre-populated ones straight from your software, you can go into configurations and reformat it. Like you can change your care plan around. Yeah, so that's
cool
under configurations. Yeah.
I might have to talk to so not all of us have the same access. I'm sure George has got full access, but the if you're not a partner, sometimes you don't have as much access to this stuff.
That's good to know. And there was a question from Shabashi earlier on as well, saying, can a regular GP do a review? Oh no, so that's not it. It was down further. Sorry. Can EPC be done to a regular allied health without a GP management plan and TCA review, as the regular GP is not available? From my understanding, if they've got a regular care plan that's already in a cycle, you can just do, and the billing numbers have been done, recently, you could just print out that EPC cover form, and we know that that's going to work. I don't know if that answers your question, Sabashi, or if she means that if the regular GP is not available, they've come in for a care plan and the doctor's on annual leave, well, they need to see a physio. I suppose you can still do it, but obviously you've got
as long as the care plan is still active.
I think we're a member of the team, aren't we? So I consider us a member of the team, so that I go, I check and see that there's been correspondence and all that sort of stuff, but yeah, I figure we're a member of the team, so we should be able to work as a team and do that referral.
Yeah, as long as you have had a review done on it, it's still active, you can still go in and add a EPC to it. It's just you would be claiming it as a time-based consult.
Yep.
I think the other thing to know is I guess we've only got one registrar on, but it's good for registrars to know there's lots of politics around this in different practices as well. So I think when you started a new practice, it's understanding what the how the practice wants you to do it, what your colleagues. So some colleagues will be very protective of their team care or their care plans, not want you to touch them, and then others will be like, yeah, go for it. I'm sort of on that end. I'm like, just do it. I don't want to do it all. But yeah, so you've got to really be careful of the politics within practices and different GPs. I think that's just a tip for young players when you play.
I'm probably more protective because I put a lot of detail into them. It's like a problem list for me.
Yeah.
Especially with your older patients, and you tend to bulk bill them in between because you've got your cream at the end with a care plan. Yeah. So if someone comes and does that care plan when I've put in so much effort with that patient, I'm like, wait a minute, where's my icing on the cake?
Yeah, no, that's right. It's this whole
Yeah,
idea of
right,
poaching
okay,
patient. Yeah.
And if I was away and they needed it, that's fine. But usually their care plans are active. They should have just done the EPC form, because they don't need to have that billing, because it's already been done for that team care arrangement to actually take place. But
It sort of comes out of that professionalism thing, doesn't it? It's sort of,
yes.
I think that idea of, because I don't mind if someone bills it, then I'm like, that's fine, but now you take care of my patient.
Yes.
So because you've taken that on.
Yeah. And look, obviously, if they went to see that doctor for a cold and they walked out with a care plan, you'd be like,
you'd be pretty. That's pretty unprofessional.
Yeah, that was Kelly making a comment that she misses her well-formatted hospital notes issue list. Will be my goal to make them look similar. Yeah, and that's exactly where my problem list care plans come from. Is I need a problem list to keep myself focused on my patients, just like the old hospital days. Like when you do a geriatrics term and you've got your problem list. But I think, on reflection, I think mine have been quite clinical, and I'd like to add a bit more sort of social factors in there. Like adding the home care. Exercise classes that they're doing, transport. I think that's all really important.
Really good points. I'm the same, Georgia. I have to add more of that this social stuff. But I think the problem list is good. And one thing, Kelly, I'd say is it's a lot of work initially, but once you've made the problem list, it's actually quite easy to update it. So it feels like you're doing all this extra work, and I often do it without the patient present or, in my own time. But once you've done it, it's heaps easier. So put in the groundwork and it'll make your life so much. And it makes it easy. So when other doctors see your patients, you just go, okay, that's where it's all up to. You're not searching for that hematology letter from 5 years ago that explains why this person's still got low platelets or something. You just see it and go, oh, it's already been investigated. Boom, I don't need to worry about it. So it helps everyone.
I've also noticed, just talking to GPs, a lot of practices use their nurses for care planning. And then I have spoken to doctors that have come on board and started doing their own. And it's surprising the feedback you get from GPs that say, I've learnt so much about my patients by doing my own care plans, things that they hadn't considered or didn't realise the extent of. So care planning is very beneficial in general practice. So yeah.
And I think that is beneficial, but what frustrates me is all this little red tape that,
Absolutely.
I probably haven't been compliant because I've got the signed form for the podiatrist, but no details of,
Yes, I find that so frustrating, Georgia. That TCA thing where you can't bill it on the day, and I find it just leads to, it's just a process thing, and it's I understand the theory behind it, but in practice it doesn't work. It's just
You really need to dedicate a staff member to monitor it.
Do it.
Yeah.
And then someone has to pay that staff member to do that. It just doesn't work. It's anyway. I mean, we need to do it, but it's just another.
Look,
it's not helpful.
Medicare, under the task force review, they were reviewing the care plans and the whole model. Look, that's been going on for a number of years now, but hopefully something may change and it might make it easier for the GPs. We can only hope, can't we?
And I know why they have those rules in place, because there are some, practices that might rort the system, and we've seen various quality care plans and some that pretty much don't have much meat to them at all. So I understand that, but but then you've got people like us that are doing comprehensive, problem-based care plans, and then if we get in trouble for not having that right approval from the podiatrist before we bill the number, then that's difficult. So yeah.
I think what really demonstrates is that it's putting the Medicare issues aside, there's a lot of value, I think, from having care plans and taking the time of your patient. And I really like that comment about the GPs, because it's so true. I think it's really important to involve our team and our practice nurse, but the GP has to be engaged as well. And the GP has to sit down and spend that time reviewing the file and doing all that stuff to make it really valuable. And I think if you do that, it makes such a difference to your patient's care. So I think that's the one tip I'd take away from this, is that care planning is important and collaborative care is important. It's just how do you navigate the system to do that?
And we have nurses that can do them at our practice, but I tend to do mine myself because I know about them. I like to, you know, be in control of what's going on, but it can be useful if the nurse gets the process happening, and then you can just add to it once they've done the initial components. But yeah.
And another thing, and sorry, Georgia. And
right.
another thing is just reviewing the patient's goals. And I really find what's very telling is the exercise goals. So I don't necessarily review it 6 months. So, but in a year, the exercise goals may have changed. And so they might have been doing 30 minutes 5 times a week. And then they go, oh no, I just can't do that anymore. What with my sore knees and my, you know, and then we actually have a proper discussion about exercise. So that sort of comes out of the goals, and then we reset the goal. So I mean, other things like hemoglobin A1C might not change, but those more sort of personal ones to the patient, like diet and exercise, can really make. And it also makes me realise how much this person's life has changed with various disabilities as they get older, and that's really good to know.
I think the key point in setting goals is the goal is for the it's the patient goal, not the GP goal, and it's got to be achievable. So don't set the goals too high where the patients can't achieve it. If they can achieve it, and then you can move on each time you review, the patient then will stay engaged.
Yeah, I agree. It's got to be the patient's goals, and that's why they change, because the patient's goals change.
Yep. Well, that was really great. Thanks everyone for joining this morning. Thanks, Mel.
Thanks everyone. Thanks to the presenters, and thanks to everyone for being here nice and early. I hope you all have a beautiful day. Just a reminder to please complete the evaluation and Slido link. I've popped that in the box twice there, so just scroll up. We really value that feedback, and it's really great to have your chance to have your say and be able to have that input. So please complete that. We are recorded, and I will send around a link as well after that, after the event. So thank you, everyone. Have a beautiful day, and I'll speak to you all soon. I'll see you at the next session.
Thanks, Mel. Thanks, everyone. Thanks, Georgia.
Bye.
Bye.